we could have all the presenters up front here, we'll have a chance for some questions before we have a coffee break. Dr. Fulton, would you like to join us in case there's some questions about pathology and interpretation?
Yeah, so that's one of the questions we always struggle with for a right answer, just like in low-grade lymphoma. The options are many, and there is no randomized studies to say, okay, this is the way you should be going. On the other hand, we can always use some principles like, as you said, if the patient is elderly, the definition may vary, but if the patient is older with comorbidity, performance status is poor, or they have organ dysfunction, and they have a CLL that needs treatment, certainly one could opt for a regimen like BR. BR certainly is tolerated much better by these patients, although one has to remember sometimes bendamustine can cause prolonged cytopenia. That could be a problem in these patients. That is an option. And secondly, the old chlorambucil is always, something we can use, plus one of these new agents, although they are right now approved in the setting of relapsed disease. So you could start patients with bendamustine if they are not tolerating. Same thing, if you start with chlorambucil, they are not tolerating, you could switch on to either ibrutinib or idelalisib. That is what I have been doing in the older, frail patients. In a younger, healthier patient, of course, the approach is different. I think based on the review of all the data, I still feel, or at least that is one thing I agree with the MD Anderson group, that is FCR, I think, still is the best regimen for a fit, young, healthy patient, because that still has the longest remission duration. And as we know in these diseases, the longer the remission with the first treatment, the more better are their options. You see every year, every other year, new drugs are coming up. So that's my approach.
Dr. Venugopal, so Revlimid with R-CHOP, based on my understanding, has been shown to be superior, has been shown to provide superior disease-free survival in activated B-cell, diffuse large B-cell lymphoma. Would you recommend that in those patients?
R2 CHOP or Revlimid, yes, Rituxan, and then CHOP has been shown to be effective. There is no question. If you look at the response rates and progression-free survival is better, but the toxicity is always a concern, especially with the lenalidomide causing cytopenias, and we don't even know how much the venous thromboembolism matters there. So honestly, I don't think I would consider it as a standard of care, but there is a lot of promise for that, especially if you are able to reduce some of the other components of CHOP and utilize the immunomodulatory activity of Revlimid in controlling the disease.
Sure. In fact, the study did not show substantially higher rates of toxicities compared to R-CHOP in this R2 CHOP.
Right.
Do you agree?
Yeah, I agree with you. Only thing is that the cytopenias have always been a concern, even though it didn't become statistically significant.
Sure.
Katrina.
Oh, okay. Yeah, I'm sure the hematopathologist may be able to help me too. So the so-called gray zone lymphomas, gray zone means, for me, it means I don't know. So there's a gray zone lymphoma between diffuse large B-cell lymphoma and Hodgkin's, and there's a gray zone lymphoma between diffuse large B-cell lymphoma and Burkitt's. And day before yesterday, only in our lymphoma conference, our hematopathologist, in fact, diagnosed one case with both gray zones, because, in other words, giving me the option to treat it as a Burkitt, diffuse large B-cell, or Hodgkin's. But in any case, I think, coming to the point, these are cases where clearly we know there are overlapping features, immunophenotypic as well as morphologic features. And treatment does impact treatment. I don't think we have honestly much to say based on randomized trial to say this is the way to proceed. For example, if it is Burkitt lymphoma, we know the standard of care would be a multi-agent chemotherapy like hypercvad 8 cycles and leave them alone. No maintenance, no transplant consolidation. Whereas in some other areas, it is very clear that we need a different approach in these patients. For example, double hit lymphomas. If you have a patient with diffuse large B-cell lymphoma and is c-MYC negative, and c-MYC positive, and also has either BCL2 or BCL6 positive, they would satisfy the criteria for double hit. There, we know they need treatment more intense than standard garden variety of diffuse large B-cell lymphoma, where you may elect a treatment option like a EPOC regimen or even hypercvad, even consider consolidation with an autologous stem cell transplant.
Comments? I would also welcome questions from our primary care providers who are very important partners in managing our patients.
I'd like to ask, the RISE stage, which is such a traditional way of staging chronic lymphocytic leukemia, and it's still important, and I think that it still plays a role in deciding when to begin treatment. Mm-hmm. Are there other cytogenetic or other markers that should play a role in that decision rather than just the traditional RISE stage?
Yeah, I think that's a very good question. In the last several years, as I have shown some of the examples, there is an explosion of all these prognostic factors in CLL. But the simple fact remains, even if a patient has the worst prognostic features, they don't mean indication for treatment. You can still wait for standard indications of treatment, even in the patients who have worse prognostic features. People already did the trials. In fact, there are 2 large trials, one from the German group and one from the United States, looking at the feasibility and efficacy of treating patients with high-risk disease who are not symptomatic and who are not eligible for treatment based on our standard established features. So they looked at patients with CLL with high-risk features. Say they treated, half of them they treated with regimens like FCR, and half of them observed. Clearly, the response rate was high, duration of remission was high, but there's no long-term benefit by treating these patients just based on their high-risk features, unless they have symptoms or an indication for treatment. So, in other words, simple thing is, even if a patient has high-risk features, whether cytogenetics or gene mutation or protein expression, there is no evidence now indicating that treating them early makes a difference in their long-term outcome. Sounds like there's a pharmacist in the audience, right? Yeah. Okay.
We have Yvonne here. Will you be able to?
Yeah, I mean, obviously these are new agents. We are going to face this. For example, there was a question of bleeding, increased bleeding with these drugs, and in the initial clinical trials, anticoagulation combination was also something that excluded patients. But I don't think that panned out to be a problem right now. It seems to be very low. But I don't think so. Yeah, but these are new agents. I'm sure we may be finding out new problems as we go on. Just like the direct antithrombin inhibitors, we find new things. Yeah. Good.
Since CLL is sort of weakly positive for CD20, should we be combining a different monoclonal antibody with ibrutinib in this disease, rather than all these trials with Rituxan and ibrutinib?
Yeah, I think that's a very good question, because you are absolutely right. There's a very nice diagram looking at all the different types of B-cell malignancies, and CLL is at the bottom, hairy cell is at the top. This is based on the expression of CD20, to emphasize the point that CD20 expression is very, very low in CLL. That is why if you give 4 doses of rituximab to a patient with CLL, the response rate is like 12 to 15%. Whereas the same 4 doses of Rituxan, if you give to a patient with hairy cell leukemia, the response is like 80%, because they have so much CD20 expression, which clearly tells the expression of antigen is important. But in CLL, it's not just the expression, there are other factors also. In fact, if you look at the serum of patients with CLL, they have a lot of soluble CD20 floating around. So once you give Rituxan, they bind to the soluble CD20 and becomes ineffective. So there are many other reasons also for the lack of efficacy, not just the antigen expression. But coming back to your point, you're absolutely right. Looking at that point alone, the expression, it may, appear that, using drugs like ofatumumab, which actually binds to a different epitope, or obinutuzumab, which actually works by even different mechanisms like apoptosis, because most monoclonal antibodies work by ADCC, the antibody-dependent cell-mediated cytotoxicity. That is the mechanism for most, including rituximab, whereas obinutuzumab has more direct toxicity. So maybe you're right, but we don't have the data at this point, because these newer antibodies are new, and ibrutinib is new. And I'm pretty sure in the next few years we will be seeing that data. So you're talking about a patient with large cell lymphoma who went through R-CHOP standard treatment. Either they didn't respond very well or they came back with disease, but you are not able to proceed to the standard of care second line treatment and then take them to transplant because they are not able to tolerate the second line, right? That's a question? Yeah, okay. Yeah, I have a typical older patient with so much comorbidity, you cannot give them second line and they are not transplant candidate. We look at other options, and that is where some of these agents, like, for example, immunomodulatory drugs like lenalidomide, certainly something to consider. Velcade, there is data on Velcade combinations with rituximab. Gemcitabine is certainly another appropriate combination. And these new agents, BTK inhibitors, they are being looked at in the refractory setting also. I think those are some of the things I can think of at this point. Combinations like gemcitabine, cisplatin, if the kidney tolerates, you can use that. GCD is something Michael Crum from Canada has published in 2004. It's very effective, not only in hard skins, but also in non-hard skins. And the beauty is that is something where gemcitabine is something without cumulative toxicity. If they respond, you can maintain them on a regimen to give them some quality of life.
Dr. Shah, I was interested in the data that you showed with regard to maintenance Rituxan and these low-grade lymphomas. And one of the conclusions was that quality of life was better in patients on maintenance Rituxan. And that seemed to be perhaps one of the only advantages of using maintenance in these patients. I'm just curious, why do you think quality of life per se would be better in patients on maintenance Rituxan versus observation?
Oh, so in fact, as you know, in many patients who have low-grade tumors, either lymphoma or many other diseases like CLL, they feel that they have a cancer inside their body and it is growing and they are anxious all the time. As you see, many of our patients come to our clinic and say, "What is my number?" That will be their first question the moment you enter the room. That tells us the amount of anxiety they go through. So giving them rituximab maintenance makes them feel that they're receiving some sort of treatment to control the disease, and that may be helpful. In fact, that is the primary reason why they decided to look at quality of life in these patients.
Are there other anti-CD20 monoclonal antibodies that are being used in these low-grade lymphomas that might be added to or substituted for rituximab?
Nothing is approved at this point, but they're being looked at.
When I treat patients with FCR for CLL, sometimes I'm surprised by shocking and refractory thrombocytopenia, which prevents continuing the therapy. Is there a way to predict who that might happen to so that you can avoid that problem? I was always employing the method of just keeping my fingers crossed. And that's not very effective therapeutically.
I don't know of a method better than what you have. So you're absolutely right. Just like I mentioned about bendamustine, bendamustine is the purine analog and alkylating agent, right? I mean, fludarabine is a purine analog. So purine analog sometimes can cause prolonged marrow aplasia. In fact, I have treated patients 80-year-old with ATG and cyclosporin as aplastic anemia because they didn't recover anything after 3 months after receiving FCR. No, not FCR, that is bendamustine rituximab, because I don't typically give FCR once they were above 65 years old. It's very difficult for many of them to handle that. So yes, I don't have any specific indicator to say that, okay, this patient is likely to develop cytopenia and this patient not. Except the marrow. I always do a marrow before I start a regimen like FCR, especially these patients are older. If there is any concern of myelodysplasia, if there is even mild dysplasia, that may be something I will consider, trying to keep away from purine analogs or bendamustine.
Mm-hmm. Yes. Yeah, fludarabine we have. Fludarabine there is, as you know, even with the low-grade lymphoma trials, we did one too. Our own 40 patients have MDS and AML. And from MD Anderson also, the famous Peter McLaughlin's data, the FNDR regimen, they ended up having significant numbers. But in terms of bendamustine rituximab, I don't think I have seen published data. It may be because in this country, it is relatively new, right? I mean, we got the approval in 2008. That was the first approval, so 6 years. Although it's an old drug, developed in East Germany, but it has not been systematically studied, so that is why we don't have long follow-up.
Yeah, there is no published data on myelodysplasia or acute leukemia from bendamustine at this point. I mean, a lot like we have for some other molecules.
We have a very large teaching hospital, several clinics where house staff basically see a lymphocytosis or relative lymphocytosis and order a blood flow cytometry. And then a stream of consults come in where there is 5, 10, 11, 13.5% cells which are of a monoclonal origin in a patient who is otherwise likely to live another 30,000 years. Are you starting to see that, and how do you deal with that? Because our pathologists are really overwhelmed by phone calls saying, can you look at the smear and what do we do next? And then, of course, it defaults with the hematology consult. When we are even more befuddled because medico-legally, we are stuck doing bone marrows and doing things that we would otherwise have ignored, saying 12,000 white count, 55% lens, leave it alone, come back in 6 months. But the blows sort of force your hand.
Sure. I think I saw a bit more of that in residency. I think people maybe are a little bit more relaxed around here. I don't see a lot of that. I don't know if Dr. Shaw gets a lot of consults, but usually it's people that, if it's being sent for flow, it's somebody who has a definite, a high.
Once the house staff finds the flow, that's the next thing they order. There's so many interesting patterns come up with. So
Right.
look at that. I wish I knew what the hell is meant.
Right. Well,
Maybe a virus passed through or whatever.
maybe it's because our
They were in a polar vortex or.
yeah. Maybe it's because our flow is so hard to order. I don't know, but we don't get a lot of a lot of crazy ones. And if it's something that I'm not sure why they're ordering, a lot of times I'll call and talk to them and try
The
to
flip side
figure
is
it
the
out.
3 patients over the last 3 years where our hematologist sort of signed off saying, why cancer from such a nonsense cancer turned out to be CLLs in we knew that eventually some of them will, that stream will become more and more dominant than monoclonal. And both the patient and the referring staff are sort of miffed saying, see, you sort of didn't pay attention, except what would we have done on a 10, 12,000 bike ambulance?
Right.
Well, it is interesting to see all these new entities, monoclonal B lymphocytosis, and now if you look at follicular lymphoma, you have follicular lymphoma in situ and all that. So it is like MGUS. We basically monitor these patients. Exactly. So of course these cells are abnormal, but at this point we do not have a way to say, okay, these are the patients who would benefit from treatment. We do not even know what is the right way to follow these patients. Like, should we follow these patients every 3 months, every 6 months? But of course, I think when you see monoclonal B lymphocytosis, I would not just dismiss that. What would you do, Dr. Venugopal? Do you agree with that?
Oh, yeah, absolutely. I agree with you. I mean, if there is persistent lymphocytosis, even if the white cell count is 11 or 12, and if we are consulted, as you said, I am obliged to do a flow cytometry, and if it picks up monoclonal B cells, then I am obliged to do something more, which may involve a bone marrow biopsy, unless it is a straightforward CLL, in which case there is no reason to do a bone marrow biopsy if you are not planning to treat the patient. So if you find monoclonal B cells in a routine CBC, just done flow cytometry done for increased white cells, I think the possibilities are, one, it could be an early CLL which is not satisfying the 5,000 ALC criteria, or it could be a follicular lymphoma in the leukemic phase in terms of low-grade lymphoma. I think those are 2 common possibilities. Then, as you said, the more recently described benign B-cell monoclonal lymphocytosis is another possibility. So, I mean, just like in MGUS, again, establishing the diagnosis and making sure that patients are followed up is the important thing. But sometimes the consults may end up as, not monoclonal lymphocytosis. We have patients with EBV or infectious mononucleosis coming with lymphocytosis, which just subsides in the next few weeks. It can happen. But we are obliged to do certain minimum things.
I was interested when you were describing some of the newer agents that are being used in chronic lymphocytic leukemia. The agent that you described, ABT-199, which is an apoptosis inducer. Mm-hmm. I'm curious if you can talk about how the mechanism of action would work and be specific for the CLL cells, because if you unleash apoptosis in the whole organism, you could be looking for some problems.
It's absolutely a very, very valid point, yeah. So CLL, unlike when we say lymphoproliferative disorder, CLL is not really a lymphoproliferative disorder, right? It's a lymphoaccumulated disorder. Basically, the lymphocytes accumulate because of the BCL2 overexpression, which inhibits the apoptosis. So essentially, BCL2 inhibition is releasing that inhibition. That way, these cells undergo spontaneous cell death and apoptosis. And clearly, that advantage will be to those cells rather than the normal cells. I don't think it can in any way influence the programmed cell death of other normal cells. So these inhibiting factors, I don't think that issue was there in any of the BCL2 inhibitors trial. The best BCL2 inhibitor we had before this was the Oblimersen, Genosens, and it came close to FDA approval. Still, the Kanti Rai worked hard on that, and the results are so impressive, but for technical reasons, they couldn't approve it. So I think the point I'm saying is, we do have some good experience with BCL2 inhibition, not just this ABT. And I don't think we have seen a concern where that inhibits or induces apoptosis in other cells.
I'm reassured.
Makes me feel better.
Dr. Shah, I was wondering, the data that you described for idelalisib in refractory lymphoma was so dramatic. Do you think that this agent is going to be brought forward into first or frontline therapies for this disease soon?
Well, as you know, the development of new drugs, basically they try and patient subsets who have very relapsed disease or poor prognostic disease. And once they are shown to be effective in those subsets, then they try to bring it to the front line. So I believe idelalisib would be definitely be looked at in frontline setting for the treatment of lymphomas. And it will take time because phase 3 trial will take a long time, as you know.
What would you expect they would combine it with at first, or would it be single agent?
I'm not certain, but probably idelalisib with rituximab would be one of the potential options, because rituximab, as you know, you try to inhibit more than one pathways. So you have idelalisib that inhibits PI3K, and then if you want to do anti-CD20, and that may basically have synergistic effect in terms of killing the cancer cells. So probably combining it with different other monoclonal antibodies or other molecular agents.
I have a lot of questions, so I'll continue since I don't see any other hands up there. In the workup of these high-grade lymphomas, the IPI, the International Prognostic Index, is still an important feature that will help us decide when and how aggressively to treat. But you also mentioned the DNA microarray, which really adds a lot more information about that. Is that something that should be done on every patient with this diagnosis? And I guess that also applies to lower grade lymphomas as well. How much workup should we be doing initially when we see these patients? Because all these tests, these microarray tests, as well as the other FISH and cytogenetic and other biomarkers, are expensive. And how far should we be going in this workup initially at this point in this country, and not just at a research institution or a university?
Yeah, I agree. I mean, the microarray certainly is giving us a lot of information, but I don't think there is a reason to do that in every patient at this time with what we know about it. On the other hand, there are certain surrogate markers we can do which might give us the information about the categories. For example, one I showed you was based on the microarray pattern. You can put patients with diffuse large B-cell lymphoma into two categories. One is the GCB and the other is the non-GCB. And you can do that even without microarray. For example, just immunostaining CD10 positive, you would categorize it as a GCB. I would hope the hematopathologist agrees with me. So if you have the CD10 positive or CD10 staining, MUM1 staining, BCL2, so based on that, you would be able to categorize them still without actually doing the DNA array at this point. But on the other hand, if I look at the big picture, in the coming years, I think we are going to group these diseases based on their molecular pattern and not just disease names. For example, diffuse large B-cell lymphoma, maybe in 5 years from now, we may not be even using that term. We may be using a germinal sentinel phenotype, CD10 positivity, and what are the expressions of the, based on what is the drug that is effective. I mean, look at it. I mean, for example, Dr. Shah treats lung cancer. I don't know anything about lung cancer, but I know that one of the genes that is very important in treatment in lung cancer is the ALK, anaplastic large cell lymphoma kinase. And what has that got to do with lung cancer? And it is even now therapeutically important, right? So these borders with names, lung cancer, breast cancer, I think it may disappear in the future. We may be naming tumors based on their phenotypic, immunophenotypic, and molecular characteristics, which is important in prognosis and treatment and not just names. That's my feeling.
Oh, absolutely agree. And gene microarray, as you know, even though it is highly prognostic, at this point you do not really make treatment decisions based on those findings. For example, these surrogate markers, if you utilize them, their sensitivity is approximately 80%. Is that correct, Dr. Venugopal?
Absolutely.
So they can, with 80% accuracy, they can tell you whether the patient have germinal center B cell, germinal center B cell type or activated B cell type, and diffuse large B cell lymphoma. Follicular lymphoma, low-grade lymphoma, on the other hand, there are some genetic microarray studies coming up, but they are not as well defined as they are in diffuse large B cell lymphoma. But of course, the future is to try to see the biology of the tumor with gene microarray and try to target the treatment based on that biology.
Do you think that adding anti-CD30 monoclonal antibodies to rituximab, which is an anti-CD20 antibody, will become prevalent, prominent, and should we be adding other monoclonal antibodies against other cell surface antigens in lymphoma so that we have a triple attack, not just a double attack? What do you think the future of that concept is?
Yeah, I think, as you correctly said, and as Dr. Shah also emphasized, we have to attack these cells in different pathways which are not cross-resistant. So the ideal way would be, of course, attack a pathway, along with that attach a protein on the surface of the cell, and that is what exactly is done with the ibrutinib and rituximab, right? You have a monoclonal antibody which is targeting a surface protein, and you have a small molecule which is targeting a specific pathway. Of course, I mean, if we can inhibit every single pathway without, increasing the side effect, that would be ideal. But how much we need to eliminate the last cancer cell? We may not need all of the inhibition, because many of these pathways, we use this fancy term, the driver mutation or the driver pathway. That is probably the important one. The other pathways may be still just there, but not really, implicated in the actual tumor growth. So coming back to the point, the trick is in identifying which is the driver mutation or which is the driver pathway. So you inhibit that with the minimum, needed treatment. And that is where these combinations will pan out, whether it is monoclonal antibody with small molecule, or is it two pathways that needs to be inhibited. Monoclonal antibody doesn't have a role, we don't know that. Hopefully, these phase 2 and phase 3 trials, as they accumulate, we may get directions to that.
Any other questions? Been a very interesting discussion. Thank you very much. We'll take a coffee break and resume in how long? 15? I don't have my program. Is it 30 minutes? All right, we'll see you back here.